Okay, well, welcome everyone to our September Geriatric Competency Series. We are doing suicide in older adults with Nirmala Dhar. And we're doing this this month because September is Suicide Prevention Awareness Month. And there are a lot of really great resources and activities happening across the state. You'll be getting this slide with the live links to all of these different resources, and please do share them out across your social media. The entire month of September, we will be doing lots of promoting across the state. So please mute your mics through the training. Utilize the chat for questions and comments. You will receive a follow-up email with the slides, a link to the recording, and any training materials that Nirmala wants us to pass along to you. You also will receive some surveys to get CEUs or your certificate of attendance. The recording will be posted to our OBHI YouTube channel, but to get your CEUs, you have to have live attendance. So you have to complete that survey, and then PSU does our evaluations. So look out for an email from the IOA evaluation, and that is the person who will be sending out the survey to see how we've been doing and any suggestions of future trainers or topics. So the Behavioral Health Initiative for Older Adults and People with Physical Disabilities was started in 2015. We have 24 specialists across the state who are working to improve access to behavioral health and wellness services for older adults and adults with physical disabilities. And we work on doing complex care consultations, workforce development trainings like this, building knowledge and capacity, and we also do a lot of collaboration and coordination with all of our key community organizations and partners. And then we also let folks know we do have an upcoming training, Hospice 101 for behavioral health, and we're going to be looking at what hospice is, but then also how does it look like for some of the more marginalized populations, for people who are unhoused, living with serious mental illness, and all the different behavioral health supports that can be possible with hospice. Okay, so we will stop share. There you go. And I will give our intro over to the other Angela.
Good morning, everyone. I am thrilled to be able to bring back Nirmala Dhar. We are thrilled. This is a collaboration, many hands. Just wanted you to know a little bit about your speaker. Nirmala is a social worker with over 36 years under her belt. She is the Older Adult Behavioral Health Lead Strategist for the Oregon Health Authority's Division of Behavioral Health, the Project Director for the Older Adult Behavioral Health Initiative, and the PASSAR Level 2 Coordinator for the state. She is also a thought partner and instrumental in standing up our new Center for Excellence for Behavioral Health and Aging at Portland State University, OHSU. Without further ado, I turn the mic over to Nirmala.
Thank you, both the Angelas and Janine, for inviting me, and I'm very thrilled to be here. This is a very important topic, especially as you know, this entire month is Suicide Prevention Awareness Month, so it's very timely. This topic. My learning objectives are really simple. You will know more about suicide in older adults. You will know about the connection with depression and suicide. You will have more in-depth knowledge of risk and protective factors. You will absolutely learn why it is important to assess for suicide risk. And then, we'll briefly touch on some treatment interventions and prevention strategies. So, as Angela Franklin's, shared that first slide with all the resources. This is Suicide Prevention Month, suicide prevention awareness, and why is there an entire month for that? And by the way, there's also a global day, which is also coming up. This is the reason why. Take a moment to reflect on this number. In 2022, almost 50,000 people died by suicide, 49,449. And by the way, that was the highest number since 1941. So it was an increase, from 21. And like I said, highest since 1941. And this is just a quick, snapshot of that data I just shared. But what's more important is that the suicide deaths are really the tip of the iceberg, right at the top, what you see. But see look at the numbers for people who had serious thoughts about suicide, right at the bottom. 12.8 million adults, that's almost 13 million people, had very serious thoughts about suicide. 3.7 million made a suicide plan. They actually had a plan in hand. And 1.5 million adults attempted suicide. That's pretty staggering. And the good news is that we can intervene at each of these points, whether you have thoughts, whether you've made a plan, or whether you have attempted suicide. Globally, the number is almost 1 million adults globally died by suicide. Look at the methods. By far, firearms. And this is national data. In Oregon, it's even higher. It's more like 62%. Followed by suffocation, followed by poisoning, which is often like medications. They're taking medication. So it's just called poisoning. And then other means. And so, people always tell me, why do you always share this data, Nirmala? It's so boring. And, what relevance does it have to us? These are all what I call statistical risks that you should consider when you're doing a suicide risk assessment. My gosh, is there a firearm in the home? Is this a male? Is this a white male? Those are all statistical risks that you absolutely should include in your assessment. So firearms is the leading cause of suicide deaths nationally and in Oregon. And then there's a gender difference. As you can see by those blue bars, men die at much, much higher rates than women. Yes, women make more attempts, but men die. And by the way, they die at this disproportionate number across the lifespan. But it's much more marked with older adults, but there's a huge gender difference. So if you are a clinician sitting in an ED, it should raise a red flag for you if it is a man and it's a white male who is expressing ideation. So that's where you connect all this boring data to your assessment. Wow, that's a statistical risk that I need to be aware of. And that should go into my evaluation or my assessment for risk. And look at people age 85 had the highest suicide rate in 2020. This is national, but they continue to have the highest suicide rate. That top bar. Again, age is a risk factor. That all of you who do suicide risk assessments or are concerned about someone, you should absolutely be aware that the older you are, especially if you belong to that old group, very high risk for suicide. And you include that in your assessment then. By race and ethnicity, guess who has the highest suicide rate by race and ethnicity? It's American Indian or Alaska Natives. That is that blue line on the top. And you can see the trend is that it's going up, followed by white or Caucasian white. The groups that have very, very low levels compared to the other two groups are Black or African American, Asian, and Hispanic. But you can see that those are the three lines at the very bottom. But even those you can see are gradually going up. Again, this should all be part of your risk assessment. Absolutely, race and ethnicity is a risk factor. So when you're doing an assessment and you have, say, if you have a Native American male sitting in front of you, absolutely, that's 2 red flags. And then there is rural and urban suicide rates. It's very clear, right? The red dots are rural, and the kind of the gold dots on the top are urban for males. And clearly it shows you that you have more suicide deaths in rural areas than you have in urban areas. Very similar for women from 2010, gradual increase. In blue, the blue dots are female rural, and the pinkish dots are female urban. Again, what does this tell you? That people who live in rural areas have higher risk for suicide. And guess what? Almost 37% of Oregon's population lives in rural counties. So this becomes a huge risk factor when you're doing an assessment. And then I want us all to be very mindful of our language, because suicide language has changed over the course of these 10 to 15 years. Remember, we would all say he committed suicide. Oh, he had a failed suicide attempt, or his suicide was unsuccessful. What we are suggesting now is language that says he died by suicide. He made a suicide attempt, or he attempted suicide. You can even say he killed himself by suicide, or he suicided, but not he committed suicide, or the other phrases. So be a little cognizant of the kind of language you use, because language has changed and language matters. Okay, so here are some highlights about older adults and suicide. Late life suicide receives very little attention compared to younger age groups. So I'm very glad we are having this training today, that the Southern Oregon group put this together. Internalized ageist stereotypes are associated with the reduced will to live. When your society and culture erases aging, or tells you repeatedly that aging is ugly, that you should just disappear, you are no good, it's very difficult to feel positive about yourself. So really one of the key messages here is, how do we in Suicide Prevention Month, is how do we bust this ageism, this bias and prejudice, because it contributes to late life suicide. So why is it important for you to know and be concerned about late life suicide? Older adults are the most rapidly growing segment of our population, not just in Oregon, but nationally. It's the biggest cohort ever, to age is the baby boomers. It is currently, I think, 77 million strong. Older adults have higher rates of suicide than any other segment of the population. I just showed you the data, and I told you this is a significant red flag for any of you who do assessments, a suicide risk assessment. And suicide behavior is more lethal in later life. Why? Remember, I said there's a gender difference. Men far outweigh women in suicide deaths, and that they use firearms. And then this is the other fact. Older adults are more frail, and they're likely to die or less able to recover from a suicide attempt. They are more isolated. Maybe they live rurally, they don't drive, they don't have a huge social network. And so they're less likely to be rescued. Like no one may even know, that they're thinking about this, or they've even, have died by it in their home. And they're more planful and determined. So they are not going to express to you, yes, I want to kill myself. It is more planned and more determined. So it becomes even more difficult to identify and assess. And I like this little flowchart, which really tells you, and what happens in someone, especially someone older. So you begin to feel hopeless and you despair. You consider life to be unworthy to live. Life is not worth living. You passively want to pass away. I wish I would go to sleep and never get up. Then you start having thoughts, ideation. Very soon you're planning. And then you may do a number of attempts, and finally you die by suicide. So I just thought this was captured very well in one kind of flowchart for all of you to understand, how do you get from feeling hopeless to dying by suicide. So I love this. This is the 5 dimensions of risk for older adults. And if there's one message for you to take home today, it would be this one. It comes out of the work of Yates Conwell and Dr. Kim Warden from University of Rochester. They talk about the 5 Ds of older adult suicide. First one is depression. Second one is disease. That means they have multiple diseases, chronic arthritis, could be lung problem, respiratory problem, could be breast cancer, it could be cirrhosis of the liver. They have access to deadly means, most often firearms, but also medications. They feel socially disconnected. That's the 4th D. And lastly, there is this growing need for dependent care, because they are increasingly more disabled. They maybe can't walk as well. They need assistance to the toilet, or they need help with bathing. That is disability and dependence. So these are the 5 Ds of suicide risk, of 5 dimensions for older adults: depression, multiple diseases, access to deadly means, social disconnection, and disability and dependence. And then what they did is they took what I just told you, the 5 Ds, and you can see they have added on, what are those things, and that up the risk. And if you can see at the very center where there is that red star where all the 4 circles intersect, is access to guns. So you can be isolated from social supports. You may have chronic back pain. You're unable to work or socialize. You get even more depressed. And then you have access to a gun, and boom, you die by suicide. So I really like this 5 dimensions. So if there's anything for you to take home about older adults, it's the five dimensions of suicide risk. So we've already talked about lethality, that older adults are more likely to use firearms than younger age groups. And that holds true in Oregon, absolutely. In fact, the numbers are higher than national number, both for the rate and the means. That means are almost like 62% use firearms in Oregon. And so why is it important? Why have I spent at least 3 slides on that? Lethal means assessment saves lives. And I know, many of the older adult behavioral health specialists like the Angelas and Janine and their 24 other peers have taken a special training called Oregon Calm, where they are teaching about why is it important to do lethal means assessment. And I would strongly urge, Angela, to maybe schedule a training as a follow-up on lethal means assessment. And why is it important? By putting time and distance between a lethal mean and an individual who may be at risk for suicide, lives can be saved. So literally putting that time and distance by taking away the firearms or asking a family member to lock it, whatever it is, or petitioning the court to take it away, you're putting time and distance, and that saves lives. I like this slide too. And, again, this would be the second slide I would tell you to keep on your desk. One is the 5 dimensions. What are some key risk factors which are unique to older adults, not to younger adults? For example, if you look at medical, physical impairments, like you may be having vision loss or hearing loss. It could be uncontrolled pain. You could have more sleep disturbance, a huge number of medications, which you won't see in a lot of younger people. Also in social life changes, you're transitioning to a care facility, you've lost your spouse, so you're bereaved, and also look at biological. There are some age-related changes. So these are very unique to older adults. So I'd love for you to spend time when you get my slide deck to really look at it, because this is what I call a primer. This is like the basics which you should know, like what are the risk factors for older people. But I'm going to dwell a little bit deeper into risk factors because that's what we want you all to know when you are working with older adults. How do you weigh? How do you weigh and come up with a risk score for your for the client that you're working with? Mental health and illness, addictions is a risk factor. Personality factors. Be aware that personality disorders, especially rigid personality styles that have a hard time adapting and coping, they contribute to suicidal ideation. Medical illnesses. Presence of physical illnesses can increase your risk. Negative life events, transitions, and changes in your support network. All of those can increase your risk. Look at negative life events. It could be your spouse has died. You have to leave your home where you've lived for 50 years and move into a nursing home. Those are huge changes. Or you've just gotten a cancer diagnosis. Your adult children live on the other coast. So, you have variable social support. You can't really go to your faith community. Maybe you were a regular churchgoer, but now you have mobility problems. You can't drive. So you've kind of lost that support. So lots of things impact older adults very differently than younger age groups. And then that functional impairment, that growing, mm-hmm, need for help with activities of daily living. whether it's bathing, toileting, changing your clothes, walking. That's a risk factor. In fact, that's one of the biggest risk factor for white men who die by suicide, is this increasing dependency needs. So here is just a quick list. I went over all of them, but that are risk factors for older adults in particular. Then risk factor can also vary across racial and ethnic and other groups. Stress resulting from prejudice and discrimination, whether it is bullying, rejection, violence, is a known risk factor for suicide attempts among LGBTQ gender youth, but it is also among adults. The historical trauma suffered by American Indians, Alaska Natives, and by that I mean resettlement, destruction of their culture, contributes to very high rates of suicide. Remember, I said they have the highest rate of suicide in the United States. For men in the middle years, this is like all men, stresses that challenge traditional male roles, such as unemployment and divorce, have been identified as important risk factors. So asking the marital status of the person that you're doing an assessment on, finding out if they're younger, are you employed? Those are all key risk factors that should go into your assessment. And here I will let you read this, which is, kind of a huge number of risk factors that this study put together. So, did you know mood disorders elevate your risk for suicide? And they are prominent among older adults who die by suicide. So, obviously, elevated suicide risk is associated with a major depressive disorder, and even with less severe depressive disorders. So if you're a clinician or you are a ED nurse or whatever your role is, carefully assessing for the presence of depression is critical in older adults. And that you should also be aware of that depression presents itself very differently in older adults. And that's a whole different training that I give. I like this icon. This is just for you to take a look at once you get it. If you can see, the title says vulnerability and risk factors in late life depression. It's like risk and protective factors. So you can see in blue are the vulnerabilities or the risk factors. You're getting more chronic illnesses like cerebrovascular disease. Maybe you have a dementia, you have chronic inflammation. It's all affecting your brain. But look at resilience, grit, adaptive coping, accommodative coping, spirituality, good communication skills. Those are your protective factors. But it's this combination which will be that risk and protective factors, which can result in that late life depression, which is a risk factor for suicide. So again, quickly, risk factors are depression, prior suicide attempts, comorbid medical conditions, pain and functional decline, a decline dependent and or isolated, family discord or losses, personality styles that are inflexible and rigid, and access to guns. Those are the top risk factors for older adults. Did you know dementia is a suicide risk factor? A recent study found that older adults with recent diagnosis of MCI, which means mild cognitive impairment, or recent diagnosis of dementia, were at increased risk of attempting suicide. The findings suggest that involvement of supportive services at the time of or soon after diagnosis may help mitigate this risk. And guess what? The risk was highest for attempting suicide was highest among people who had gotten a recent diagnosis, like within a month of the diagnosis. And this study was from Yale, that the risk for suicide was particularly elevated among adults aged 65 to 74 years in the first 90 days following a dementia diagnosis. And those diagnosed with frontotemporal dementia, which is a kind of dementia, FTD, were at the highest risk. So what does this illustrate? All of you who perhaps work in clinics where you're maybe telling people you have dementia, or you're coming across in your work as a case manager, the importance is that suicide risk screening and support at the time of newly diagnosed dementia, especially for patients who are older than 75, is critical and is key in prevention. And then, did you know there are trends in seasons and time of day? I just thought this was interesting, especially when we plan programs, to have this knowledge. Seasonality affects moods and desire to die. Did you know that? How many of you feel more blue in winter when it's gray and dull and it's raining all the time? So seasonality affects moods, particularly among those who previously made a suicide attempt. Look at that. Negative, explicit self-harm cognitions or thoughts peaked in winter, that is December, with implicit self-harm showing a lag peak 2 months later, that is in February. So thoughts peak in winter. Moreover, daily negative self-harm thoughts consistently peaked around 4 to 5 a.m. in the morning. And then look at it. Explicit and implicit thoughts precede the rise of suicidal behavior in spring. So people begin thinking about it a lot in winter months, December, but actually suicides, deaths increase in spring. And the time of day is early in the morning when they are thinking. So remember I talked about depression. Psychiatric illness in older adults is present in almost 97% of people who died by suicide. You can say almost everyone who died by suicide had some kind of psychiatric illness, and most often it was a mood disorder such as depression. In young adults, it is substance use personality disorders complicate suicide. But in older adults, it's physical illness with cardiovascular disease and cerebrovascular disease playing a very prominent role in suicide risk, unlike in young people. So physical functioning is absolutely key in your risk assessment. See, beyond the number of physical illnesses, the perceived meaning of those illnesses, their impact on their functioning, pain, threats to their autonomy and personality integrity play a key role. That's why older white males die at the highest number. It's that perceived meaning of aging, disability, and illness. And then there's a strong correlation between severe pain and suicide. And why am I telling you all of this? Because these are really key points of contact where we can make a difference, or we can provide help and hope. Look at other disorders which have very high risk for suicide. Did you know epilepsy is one of the highest risks, like seizure disorder, AIDS, cancer? spinal cord injury, Huntington's disease. That means people who have been diagnosed with this early on, they're at very high risk of actually dying by suicide. And one of the highest risks, as I mentioned, is epilepsy or seizure disorder. There are social factors which influence suicidal thoughts. We talked about stressful life events and social connectedness. So if you're well socially connected, it acts as a buffer to reduce your risk, as opposed to someone who's isolated, living way out in the country with no transportation. Stressful life events preceding suicide tend to be more severe and numerous among the study where they looked at people who died by suicide. So what are those events that are most salient to late life suicide that are associated with aging? Threats associated with ill health and functional impairment, loss through bereavement, and other sources of supports. Really threats to your bodily integrity. My gosh, I'm losing my bowel movement. Oh my gosh, I have to depend on someone to take me to the bathroom. And by the way, these are real facts that catalyze older white men to die in the highest numbers, is this perceived threat to their autonomy and integrity, their bodily integrity. And, we can give a 2-hour talk on social connectedness. How important social connectedness is across our lifespan, because we are social beings. So having friends, encouraging people to make friends, having little book clubs where you're connecting with people and talking, whether it's virtual or in person, having a friendly caller, call you every day to chat with you, whatever it is, social connections prolongs life and it improves quality of life and is a deterrent to suicide. So who are at risk? People who live alone. Did you know 1/4 of Oregon's population lives alone? That was the latest data. They live alone in a household of one. And I'm not even talking overall, that was just, overall. That's a huge number. So they are at risk, people with small social networks or absence of a friend or a confidant, loss of a spouse or partner, just overall social disengagement, family discord, that you actually report feeling lonely. And low levels of social integration means you just feel you don't belong. You're excluded. Some people are excluded by their race, ethnicity, their disability, mental illness, but some people just don't feel they belong anymore. Those are all significant risk factors under this rubric of social connections. Do you take that into consideration when you are doing your suicide risk assessment? And why I keep bringing out suicide risk assessment? For many years, not so much in Oregon, but in the other 2 states, that was my main role. I did suicide risk assessments in emergency rooms for a big part of my early career. And so I just want to briefly introduce you to this theory of suicide. It's called the interpersonal theory of suicide, and it is developed by this leading suicidologist. He's a psychologist, Thomas Joyner. By the way, he has a keen, long, enduring interest in this subject because his father died by suicide. He talks about 3 things having to be present for a person to actually die by suicide. So he talks about the first one is thwarted belongingness. That, remember I said, I don't belong. I'm alone. I'm, I don't belong anywhere. And, so many of us take belonging as given or granted. So many of us have great families we belong to, extended families. It could be social or faith groups. We belong to a neighborhood group. Many people don't, and it's or feel that they're excluded. So that's a very painful feeling. Thwarted belongingness. I'm alone. The other one is perceived burdensomeness. I'm a burden. I'm just taking up space. I'm just using up resources. Nobody would really care. I'm a burden. And then the last thing that Joyner says is that you have to have that capability to die. I'm not afraid to die. We all have this built-in kind of self-preservation, right? That we don't just walk in front of a car. We don't put our hand into a fire. That's all built into our system, right? To preserve, self-preservation. How do you overcome that when you have these strong suicidal ideation? And that's what Joyner says. The people who are ready to die are able to do that. They're no longer afraid. And then he talks about, you should also have the means. He's calling it near lethal means, which could be firearms, medications, all of that. But, and all of this comes together in that middle intersection, desire for suicide. So he talks about all three of these things being present. And guess what? They're frequently present in older adults, correct? I'm alone. I'm a burden. And they have access to, means. So this is just a conceptual model, which is very good to have at the back of your mind to understand suicide. And then my great friends at the University of Rochester, the same ones I was referring to earlier, Yates, Conwell, and Van Orden, kind of took Thomas Joyner's model, you can see in the middle there, and then added on, what are those external factors which will then move older adults towards suicide. And you can see there, functional impairment, access to means, painful, life events, physical illness and pain, for that acquired capability where, you have to feel that I don't fear dying, social isolation. So I would really encourage you to take a look at the slide when you receive it, where they have superimposed on Joyner's theory, what are all of those kind of risk factors, which all kind of collide often to have an older adult complete suicide. Okay. So again, here are some warning signs that people can say out aloud. Remember, I'm a burden, or I'm alone. My family will be better off without me. I just make things work. I can't take it anymore. What's the point of living? I wish I could go to sleep and never get up. You won't have to worry about me anymore. Here are some red flags. I don't have anything to live for. If you hear people saying that, I don't want to be a burden to my family. Giving possessions away, putting affairs in orders, changing one's will, failure to take medication, which was something I talked about in my self-neglect class, or just generally saying goodbye, which is, unusual for them to do that. Acute risks are, you have a gun, you've identified a method, you were recently discharged from a psychiatric hospital, you're experiencing severe loss of interest, which we call anhedonia, which is very prominent in older adults. You have experienced a recent stressful event, like maybe your spouse has died. You are having significant sleep problems. You could be increasing your use of alcohol. So these would be like, and you are expressing hopelessness. You know, in many studies, they say hopelessness is a better predictor than anything else of dying by suicide. Can you imagine getting up every day and you had no hope? You know, you can see how that applies to suicide. And so hopelessness, a lot of the literature says it's a better predictor than anything else. So asking about hope in suicide assessments is important, or inferring it, you know, deducting it from what the person is saying. This is also a very nice icon for you all to use very easily, you know, risk factors for older adults: physical illness, bereavement, financial issues, you know, many of them retire, their income drops, hopelessness that we were just talking about, dementia we've already talked about, especially in the first 90 days after diagnosis, access to guns, family discord, and, you know, psychological issues like those personality types that I was talking about. You know, you're rigid, you can't cope. And what is aging? It's a series of transitions often, right? And so if you're inflexible and rigid, you're not going to do well. So risk is greater if the warning signs are new, they have increased, they are related to an actual painful event or loss or change, and or they are associated with an onset of a mental illness, whether it's new or old. Suicidal thoughts or actions are a sign of extreme distress and not a bid for attention, and should never be ignored. Never. Even if the person is doing it every day. It is not for attention, it is a bid, it is a call of distress. And so, you know, we want to focus on resiliency and protective factors, because that's part of that suicide prevention month. What do we need to do? Facilitate strategies with clients to develop or regain a sense of meaning and purpose. Yes, that can be a challenge. I'm not saying it's easy. We are going to look at safety planning later. Facilitate strategies with clients to enhance social support and interpersonal activities. Like they're meeting people, they are connecting to their family. Facilitate strategies with clients to encourage better health practices, including coping skills. So there is a, you know, I just went over this whole bunch of risk factors, and there's a whole bunch of protective factors that we want to encourage and cultivate in our communities. So there was this classic study published, gosh, in 1897. If any of you have sociology as your major, which I did in undergrad, we all know about Emil Durkheim. He analyzed data on suicide rates across a variety of factors, and he observed that suicide was most common among those who lacked social integration, and subsequently proposed stable social ties and norms are important to regulate behavior and are ultimately protective. So people who felt disconnected, who felt they didn't belong, were the people he looked at who were at the highest risk. And his intervention is, we need to create communities where we can develop stable social ties, and we encourage interaction. That should be the norm. So what are our protective factors? Effective behavioral healthcare, that means you have access to it. Connectedness to individuals, families, communities, and social institutions like church or a mosque. It could be also a civic engagement in city councils. Life skills, including problem solving and coping skills. That's why through our initiative, we have rolled out Pearls, which is a depression treatment, which teaches you these effective life skills, how to problem solve. How many of you routinely teach that if you're in mental health, that you're teaching problem solving skills or life skills to older adults? Imparting a sense of meaning and purpose. Cultural, religious, or personal beliefs that discourage suicide. There are lots of religious beliefs that proscribe suicide, or religious beliefs act as a buffer, stress buffer, and also buffer in the sense of you have a lot of social connection if you belong to a faith community. That is one of the reasons, when I showed you the slide on race and ethnicity, that African Americans, Asians, and Hispanics have the lowest suicide rates. It's one of very big is this last bullet point for them: cultural, religious, and personal beliefs. Even though they have some hard knocks in terms of social determinants of health and racial and ethnic discrimination, they're actually doing very well in terms of suicide. And so it's like a paradox. Why? And this is one of the reasons, is cultural, religious, and personal beliefs. So personal protective factors: resilience and perseverance, openness to experience. Aging is all about openness to experience, correct? You no longer are 16 years old. You have to make changes, adjustments. Sense of meaning and purpose, and daily cultivation of hope. High self-esteem and positive health practices, including help-seeking behaviors. Do you know the one reason why men across the lifespan die in high numbers compared to women is this lack of practice of health-seeking behavior, which, they're kind of socialized into being self-reliant. You never let down your guard. You never say you're emotionally vulnerable. You never go and ask for help. Well, women do. And if you see the data, across the board, women have better well-being. They have lower suicide rate, especially as we grow older, by the way. Men's skyrockets, and women's stays about the same, even at 80, 85. And one of the reasons is, among many other, is help-seeking behavior. The screening tool that I will talk about, the CSSR, here are some protective factors they talk about. Identify reason for living. Responsibility, family, or others, including beloved pets. Previous psychiatric diagnosis and treatment. Supportive social networks. Fear of death or dying due to pain and suffering. Belief that suicide is immoral. High spirituality, or spiritual or religious beliefs, and that you're engaged in some kind of meaningful work, even if it's not paid employment. You're doing volunteer work, you're having a second career where you're just giving your professional skills for free, like pro bono, anything. These are all protective factors. Now, the sad thing is, the majority of older adults who died by suicide received healthcare services in the 1 year prior to their death. And of those, 50% had made a medical visit within 4 weeks of dying by suicide. The most common visit was to primary care and then to specialty care, which was often orthopedics. And nobody asked them, are you feeling hopeless? Have you had thoughts about dying? Have you thought life is not worth living? Nobody asked them. And 4 weeks later, they died by suicide. They killed themselves after visiting a medical practice. So this is a key missed opportunity to reach individuals at risk within primary care and medical specialty settings. Why is it a problem? Why is having a suicidal patient in primary care a problem? Short appointments. Pace of primary care is like very rapid, 10 minutes, 12 minutes, the next patient. We call it hand on the doorknob comment. Very little, if any, training on how to assess and develop a safety plan. Like who should go home with the safety plan, who needs to be hospitalized, or even how to ask those questions. So we have a ton of work to do with primary care, because guess what? Older adults go to primary care. They're not coming to your community mental health program. It's a moral imperative. I just showed you the data. 4 weeks before they died, they were in a doctor's office. The data indicates that primary care providers need to take action, and that preventing suicide is a community responsibility. And the role of a primary care provider in preventing suicide has been underemphasized. Ask about suicide, and it doesn't increase the risk. There's this myth that if you ask, they'll go out and kill themselves. Nope. Don't be afraid to ask. Are you having thoughts about killing yourself? You said that you're feeling like you can't handle it anymore. When you say that, do you mean you're thinking about suicide? And practice it, with your colleagues, because some people who are not used to doing assessments or talking may find it strange, but the more you practice, the more normal it becomes for you, and you're saving lives.
Nirmala,
Yes?
it's 10 o'clock.
Thank you. Have you ever wished you could go to sleep and not wake up? Have you had thoughts about ending your life? Does it ever get so bad that you think about dying or ending your life? These are perfectly good questions to use in your practice. And it doesn't mean that the person is going to go out and kill themselves and die. Now, I always get the question about prediction. We cannot predict suicide. A recent review found that the ability to predict if someone will attempt to take their life is no better than chance, and has not significantly improved over 50 years. The goal of identifying risk and protective factors in a suicide assessment is not prediction, but rather to determine the level of risk and to plan for more informed interventions. I can't say, yes, 100% he's going to go and die tomorrow. No, this is not a prediction science. But what all of this work that I just told you about protective factors, risk factors, it helps you establish risk. And then very importantly, as a clinician, case manager, RN, you can then plan what kind of interventions do I need to put in place to mitigate that risk, to bring that down. Why should you screen? So the goal of suicide risk assessment is not prediction. The goal is to determine the most appropriate actions to take place to keep the person safe. Not, I'm predicting he's going to die. That's not why we do suicide risk assessments. So this is a really nice tool. It's called Safety. So you identify risk factors, you identify protective factors. We went over all of them. You conduct that questions, you ask about what they're thinking, you then determine level of risk, and then you document. I'm not going to go everything, but here would be that first safety risk factors. We went over all of them. You're going to ask, if you're in that role, you're going to weigh what are the risk factors, what are the protective factors this person is experiencing. And red, I have put down their statistical risk factors. That's why data is important. It can be boring, but extremely important in assessment. If you're seeing a man, he's older, he's white, and he has a mental illness, the statistical risk skyrockets when then you look at anything else. What is his coping abilities? Or does he have firearms? So very key to really look at what are the risk and protective factors, and what is the statistical risk of this person. And then you do that, you ask the questions, that here it's called suicide inquiry, timing, location, lethality, availability, preparatory acts, do you have a plan? Are you going to use what means are you going to use? Are you thinking of killing yourself? And again, so you focus on the who, what, where, when, how. And then again, the assurance that asking does not increase risk. And then number 4 is that risk level. Then based on all of that, you come up with the risk level. High, moderate, low. Then you document it. High, someone with a psychiatric diagnosis with severe symptoms, acute precipitating event, where the protective factors are really not relevant. They potentially have lethal means. They have very strong ideation. They may have rehearsed. Moderate, multiple risk factors, few protective factors. They have a plan, but really they're saying, no, I don't have any intent, or there's no behaviors for that. You may want to develop a crisis plan, put them in touch with emergency contacts. And then low is lots of modifiable risk factors, very strong protective factors. They have a strong social networks. They have very strong religious beliefs that proscribe suicide. They have thoughts of death, but no plan, no intent. You may do it like an outpatient referral, symptom reduction, give them some phone numbers to call. I'm hoping if you're working for agencies that you actually have a critical pathway for suicide. What do you do when it's low? So I'm hoping all your workplaces have developed that. If not, please do contact me. I'd love to have a chat with you, because really that's what we need to be developing and helping our clinicians or case managers, whoever it is. Hey, what pathway do I follow if my client is at low risk? What are some interventions based on this risk profile do I need to connect my client to? Because what we have done when you develop those critical pathways, we have standardized that care, and we are giving tools and support to our staff. What do you say when the answer is yes? Many people in primary care ask me that. Thank you for being honest. I know this can be so hard to talk about. I'm glad you told me. I might be able to help you, or we might be able to help you here. Or it sounds like you're in a lot of pain. I'm so sorry you're going through this. I'm here to help you. You may want to ask open-ended, how long have you been feeling this way? Can you tell me what led you to this point? Can you tell me the day that you were feeling most suicidal? What was happening? What did you do to cope? And yes, I absolutely recognize the tension. Goal of the person at risk is to end their life, and your goal as a helper is to keep them alive and calm their fear. And it is a constant tug of war. The very other easy mnemonic, which we teach busy residents, primary care residents, other people who are not mental health professionals, so it could be an APD case manager anywhere, is to remember this acronym is called IS PATH WARM. So I is ideation, S is substance use, P is purposelessness, means no hope, A is agitation and anxiety, T is feeling trapped, which is kind of feeling hopeless and lost. There's nothing's going to change. H is hopelessness and helplessness. W is withdrawal. Remember that anhedonia was saying loss of pleasure, you withdraw from everything. A is anger. R is recklessness. M is mood changes like depression. So this is an easy way for busy residents, case managers, etc. to remember, is path 1? I need to ask, I need to look at all of those areas to see, to understand the warning signs that my client or my patient is experiencing. And this is, by the way, used very widely. The other one is called SIG caps. I'm not going to kind of inundate you with that, but mnemonics is a very good way to remember things. And this mnemonic is sleep disturbance, interest has decreased, that is that anhedonia, feelings of guilt or regret. Energy is less than usual, your concentration is down, your appetite is disturbed, you're feeling kind of slowed down or agitated, and you're having suicidal thoughts, or you passively want to die. So that's that other acronym for depression symptoms. SIG caps. And why am I giving you that? Because I told you 97% of older adults who died by suicide had a depression. How many of you use PHQ-9 in your work? It is kind of a standard of care in Oregon to use a PHQ-9. And if you see what I've written in red, conduct suicide risk assessment if PHQ-9 score is more than 10 or response to number 9 is 1, 2, or 3. Critical to remember that. I'm not going to go over this, but these are some of those questions that I was telling that you can ask, but this is actually a validated screening tool. It's called the P4 Suicidality Screener, where you ask these 4 questions, but I will let you take a look at it when you get it. Just because of time, here are some questions that you can ask in your busy practice or wherever you work, to your client, patient, consumer. In the past couple of weeks, were things ever so bad that you had thoughts that life was not worth living, or that you were better off dead? And this is you're trying to assess for passive suicidal ideation. Have you had any thoughts about hurting yourself or suicide in the past couple of weeks? Have you been thinking of doing it? How often do you have these thoughts? How long do they stay in your mind? What's going on in your life right now? Do you have a plan? Do you intend to harm yourself? Is anything preventing you from harming yourself? For example, how strong is your desire to live? Do you feel you have purpose in life? Do you have hope for the future? Do you feel you can resist these thoughts? Have you ever done anything to harm yourself? So these are a set of questions that you can ask. So I'm going to now talk about assessment and screening. I gave you those mnemonics. There are many risk assessment tools. There's the BEC, PHQ-9, so many. But the gold standard now is called the Columbia Suicide Severity Rating Scale, short form C-SSRS. Training is not required, and you do not need to have any mental health experience to use the Columbia protocol. Why the Columbia? It's a series of simple questions that anyone can use anywhere in the world to prevent suicide. I've given you the link here if you're interested in taking the training. It is free. We also provide it, so in Oregon. But it is a unique suicide assessment tool. It's a series of simple, plain language questions that anyone can ask. Whether and when they have thought about suicide, that is ideation. Remember, I told you how many people had ideation, almost 13 million. What actions they have taken to prepare for suicide, and whether they have attempted suicide or began a suicide attempt that was either interrupted by another person or stopped by their own will in their lifetime. All versions of these 6 questions, which versions will have questions regarding ideation or suicidal behavior, such as wish to be dead, non-specific active suicidal thoughts, active suicidal ideation or any method, intent to act, specific plan and intent, and have you done anything or started to anything in the past. This is the screener that I was talking about that anyone can do. Plain English. Have you wished you were dead or wished you could go to sleep and not wake up? Have you had any actual thoughts of killing yourself? And then it tells you, proceed to this. Have you been thinking about how you might do that? And they've given you some suggestions. Have you had these thoughts and some intentions of acting on them? Have you started to work out the details? So it's very simple, plain English. Anyone can use it. This training, I'm not going to spend a whole ton of time on this. Angela Franklin is your suicide prevention coordinator for Southern Oregon. I don't know, Angela, whether you'll teach the Columbia screener. So if any of you want to get training in that, please do connect with Angela. Screeners condense to a minimum of 2 and a maximum of 6 questions. So they're good, they're short. Full assessments are lengthy. So we have the full assessment which clinicians do. This is just a screener. And we recommend lay people to use this. Anyone. You don't have to be a QMHP or anything. How do you manage risk? Remember, I'm talking all about risk here, right? If your client, is it imminent risk? Yes. Don't leave the person alone. Arrange for hospitalization. Engage family caregivers, whoever in the planning. If the risk is not imminent, but they have ideation, conduct safety plan, involve supportive network, limit access to means, take away medications or guns if possible, increase contact through the crisis, whether they're calling you or your program, or there is a church member who can be in touch with them, and arrange for evaluation and follow through. So you can see 2 very different pathways. When someone is at imminent risk, like I want to die today, as opposed to I'm having thoughts. And remember, 12 million people had suicidal ideation. So with that said, we know now what risk entails, how we assess for it, what we should do. What do you do after that? How do you respond? If you remember, 15 years ago, we would all talk about suicide contracts. I will not kill myself. I will call you first, whatever. Those were like suicide contracts. And guess what? They have no validity. All the research says it doesn't work. So let's stop doing that. Instead, we are promoting safety planning. A no suicide contract takes the form of asking the client to promise not to kill themselves and to contact you. There is no empirical evidence that supports the effectiveness of no suicide contracts for preventing suicidal behavior. So what is it? Yes?
Did you break a temper?
Okay, I will. Yeah. So what is a safety plan? A safety plan is a prioritized list of coping strategies and sources of support for persons at risk for suicide. I have a request, Angela's and Janine. Can we take maybe a 5-minute bio break? Because this is a whole new section and then we'll come back to it. Okay, we'll take a 5-minute break and we'll be back.
Yeah, that sounds good. So we will return at 10:24. Okay.
Angela, I'm back whenever, whatever time you said, just let me know.
We have 3 more minutes.
No
And-
problem. Thank you. I
Yeah.
had to take that 5 minutes. So, and I also have my coffee now, so my voice won't kind of crackle. And now I don't need to actually, we can go till the end of the time. We can go up to 11 o'clock.
Okay, perfect.
So just tell me when to start. I'm sitting here at my desk.
Will do.
And this was a good point to stop, because now we are actually talking about like the intervention, like the safety plan. So I know I have I have a lot to cover. So I may not, like I said, go over every plan, but I do a standalone training on safety planning. Just like on safety planning, 1 hour. Like if anyone wants more in-depth.
And I know that is has been requested already, so.
Right. And the other thing is, I have some really nice critical pathways, for what to do after this a risk assessment. Both I taught it through nursing facilities, but I was a co-project director for. We had done work with people, case managers, etc., who work with domestic violence, where we created that critical pathway for suicide. So which is very helpful for people. Hey, what do I do? He's high risk or low risk. What do I do? Where do I go?
Mhm.
I don't know, have you gone to this My 3 app? I have never, but Deb keeps talking about it. So
I have not.
I'm going to give the link later. It's a free app to download for safety, the safety plan.
Nice.
Yeah.
Okay, I think that we are ready to come back. So if Nirmala, if you want to get started again.
Shall I get started then?
Yeah.
Okay, well, welcome back. I'm sure we all needed that 5-minute break. This is a heavy subject. So I'm glad we could take that break. So the rest of the 40 minutes or how much ever time we have is I want to spend on safety planning and some other kind of interventions. But the main intervention I want to talk about is a safety plan. So remember I said we are no longer doing these no suicide contracts. There is no empirical evidence that they work. So instead we are suggesting, hey, this is the intervention that we should look at. And there's quite a bit of evidence for this and some others which are very similar. So a safety plan is a prioritized list of coping strategies and sources of support for the person who is at risk for suicide. That person can then use these strategies before or during that suicidal crisis. The plan generally should be brief, in their own words. So no legalese or legal professional language. It's so plain English and is easy to read. When you're in a crisis, you want something that is easy to read and easy to understand. The one that I'm going to talk about was developed by 2 psychologists, and it's often referred to as the Stanley Brown. So that's the plan that we are really advocating for its use in Oregon and actually across the country. Okay. So it is a brief intervention that significantly reduces suicide attempt. This is like the evidence. It is sometimes referred to as Stanley Brown. Very sadly, Barbara Stanley died a few months ago. So she passed away at a fairly young age. So she was one of the developers. Rather than telling the person what not to do, which is what we do in a contract, right? Do not die by suicide. The plan helps the person know what they can do to feel better and stay safe. So there's a huge difference. And what does that do? It builds self-efficacy, which means, in other words, self-confidence, and empowers the person. Hey, I can manage this crisis. So why have a safety plan? Individuals may have trouble recognizing when a crisis is beginning to occur. Problem solving and coping skills diminish during an emotional or suicidal crisis. There's something called tunnel vision when you're in the throes of a suicidal crisis. All you want to do is kind of get out of that emotional pain. You can't think of anything else. So it hugely impairs your problem solving and coping skills. The clinician and patient and their family, if it is applicable, or caregiver, work together to develop these kind of coping skills and they use the person's own words to actually write the plan. And over practicing skills, using a set of skills may improve coping capacity. That means you ask them to practice them so that it will help improve their coping. And they may also use it when they're not in a suicidal crisis. So very quickly, it creates a tool for participants to use in distress. And it's a stepwise increase in the level of intervention. It begins with yourself, and then it goes on to external resources. And you can jump steps. It's okay to advance the steps, even if you didn't totally complete it. And the good news is you can write a very good safety plan in like one brief session. You need to practice writing it if that's what you're going to do, but it can easily be done in one session. And this is how you can introduce it to the person. So you need to introduce a safety plan as a method for helping the person recognize warning signs and take action to reduce the risk before it escalates beyond their control. Describe the suicide risk curve and explain how strategies enhance confidence and self-control. This is the suicide risk curve. Warning signs begin at the bottom of the curve. Danger of acting on suicidal thoughts and feelings are highest at the middle of the curve. And if we intervene with the safety plan, it kind of diminishes. So explaining this curve, here it is. Here is the explanation that you can use. People at risk for suicide are likely to experience changes in their level of risk over time. Acute suicide risk usually increases and then decreases over a short period of time. So if you have the scoping skills through your plan, the hope is it will decrease. The goal of safety planning is for people to become aware or to become more aware of their personal warning signs that a suicidal crisis is beginning or escalating so that they can take action before they are in danger of acting. That is essentially the suicide risk curve. And so sitting down with your client, patient, consumer, explaining, hey, this is why a safety plan is important. Here is what the suicide risk curve looks like. So first is warning signs. Identify personal warning signs that mark the beginning or worsening of your crisis. Understand how identifying warning signs and changes in risk provides an opportunity to cope before acting on suicidal urges. Second is coping. Explain the purpose of internal coping strategies is to help the individual's mind to take their mind off the problem, to prevent worsening of the thoughts, and to prevent a suicide attempt. So you're asking them to identify what are those specific internal coping strategies. And we are going to get examples of them, okay? Explain how distracting from suicidal thought is helpful. Ask, what have you done in the past to take your mind off your suicidal thoughts without contacting another person? What activities could you do by yourself to take your mind off your problem, even if it was for a brief time? Someone I know said, I can go and play with my dog, or I can get up and make some coffee. Seriously, these are actual examples of clients. And if they are having a hard time, you can make some suggestions and see if it resonates with them. Here. Throwing out my extra meds, keeping my extra meds. This is an example of, I'll come back to this, but I'm just keeping it here, and I'll come back to it. Here was the free, I don't know, my slides got a little bit out of whack here, but this is a MP3. If you go to this website for Apple or Android, you can actually download the safety plan, what I'm teaching, the template, onto your phone and onto the phone of your clients or consumers. So they actually can have the safety plan on their phone. So anyways, I'm not going to go over the meta-analysis. You will get this slide deck. There's lots of evidence that safety plans work. I've already told you it is short, one session, and the intent is to lower immediate or imminent risk by consulting a predetermined set of coping strategies and a list of individual and agencies that person can contact. Here are the components. Recognize warning signs, employ internal coping strategies, utilize social contacts as a means of distraction, contact family members or friends who can help resolve suicidal crisis, contact mental health professional or agency, and reduce use of lethal means. These are the steps. I recently found this and I thought this was so great. Coping skills for late life suicidal ideation. And for each possible areas which are risk factors for older adults, they have given you some interventions that you can possibly write into a safety plan. For example, for disease, older adults have 2, 3, 4, 5, chronic illnesses. Coping skills for stresses involving lack of control, teaching them relaxation or pain management strategies, refocus attention on reason for living. So they've done remember those 5 Ds that I talked about? So they've given interventions for each of those 5 Ds. This would be very helpful for you to keep handy. So again, I'm just giving you another way of looking at, at the safety plan, the 6 steps, which we just went over right now. So how would you introduce it? For example, if you work in a hospital, you were hospitalized because you had a crisis or you had some serious thoughts about ending your life. Usually people find themselves in a crisis because whatever is going on around them is just unbearable. The purpose of our meeting today is to develop a plan for what to do if you feel that way again in the future. The goal of this plan is to reduce the emotional pain for long enough so you can get help. So that would be one way for you to introduce it. How does this all sound to you? What are your thoughts about creating the plan? Ask for permission to continue. So these are all just helpful things that you can do. Remember I said recognizing that you're asking the person to develop a recognition of what their signs are. That by noticing warning signs, you will know when to use the plan. What's it like for you to become suicidal? What usually goes on? There could be physical signs, racing hearts, headaches, stomach problem. There could be mood or thoughts. I'm a failure. I can't cope. That nasty voice in your head. I'm a nobody. I'm a burden. We talked about that. I feel hopeless. Behaviors, you're crying, you're not sleeping, you're isolating yourself. These would be all the warning signs that you will put down in plain English in the person's language, in the own word, in the safety plan. 2, internal coping strategies. Things I can do to take my mind off my problems without contacting another person. And again, you're asking, Because suicidal thoughts come and go, having a few tools to get you through those moments can be really helpful. These help you reduce uncomfortable feelings. What can you do on your own if you became suicidal to distract or occupy yourself? So you're asking that, Here are examples. Deep breathing, meditate, prayer, go for a walk. Remember, this doesn't involve another person. Watch a video, lift weights, listen to an audio book, squeeze a ball, comb your hair, dance, pick up a craft, read your Bible, sing a hymn, or any other religious book religion that you adhere to. Play a puzzle, complete a puzzle. Visualize yourself in a safe or a fun place like a beach. Read notes, cards, emails from loved ones. These are actual internal coping strategies, which CDC did a big study on. You can take any of these. You can even print this and show it to the person if they're having a hard time. And then you write it into the plan. People and social settings that provide distraction. Who can help you take your mind off your problems, at least for a little while? Who helps you feel better when you're around them? Or are there places you can easily get to when you feel safe and calm, and that would distract you? So you're asking that. Look at it. People and social settings, friend who I can talk to, buddy to talk about sports, brothers, sisters, like siblings, adult children, neighbors, pastor or clergy, other extended family, places, coffee shop, library, shopping mall, senior center, going to my church or chapel and praying, going to my hair salon and meeting my hairdresser or my barber. These are actual places and people that you can help your client put into their safety plan. So whom are your family or friends who you think you could contact for help during a crisis? How likely would you be willing to contact them? That would be number 4. Number 5, who are your mental health professionals we could identify on your safety plan? Or are there other healthcare providers? Actually put the names, telephone numbers, and the telephone number of the crisis line, which in Oregon is 988. Step 6 is that, remember, reducing the potential for lethal means, that is making the environment safe. Like you can say, as we discussed before, it's common for people to feel suicidal very quickly without much warning, sort of like suddenly feeling overwhelmed. When you're upset, thinking of alternatives or solutions is very hard. Having access to a lethal means like a gun can be very dangerous when you're in this state of mind. So making a plan to limit your access to guns for now is an important intervention. So you're explaining this to the person, which is the last step. And then you ask, how likely on a scale of 1 to 10 will you use this plan, the safety plan? What would make it easier or more likely for you to use it? And then you troubleshoot. I suggested, maybe they say, if I have it on my smartphone, I'll quickly open it. Maybe older adults who are not so digitally savvy may want it like printed on a piece of paper and kept in their wallet. So again, elements of a safety plan. One last thing that the Stanley Brown also has, which is not the 6 steps, but it's a separate section at the bottom. The one thing that is most important to me and worth living for. And I had a very dear friend who was frequently suicidal. It was her dog, 15-year-old pet, that made her get up every day and stay alive. And she actually used to put, the dog's name was Sasha. That is not the 6 steps. It is a separate section at the bottom. What is the one most important thing that is worth living for? This is how it looks. And Angela, Franklin, there are several templates I will send you. If you have, you can also share, but I have some templates also. Maybe I sent them to you earlier. I think I did in separate emails. Please share it. I've actually sent you all the templates. And as you can see, if you look at number 3, you're actually putting the name and the phone number of the person who is going to provide distraction. That you're providing every possible resource, that when you're in a crisis and you can't think straight, it's very clear, hey, I need to pick up the phone and dial this number.
Nirmala,
Yes.
just want to let you know it's about a quarter to the hour, and I know you want time for Q&A.
Yeah, I'm just going to race through this, and this is number 5, what we talked about. And then last is, if you have guns, like what plans have you made? There are lots, I've included lots of examples here. For example, personal warning signs: trouble sleeping, not eating, not taking care of myself. I think like I'm a burden for my son. Coping strategy: reminding myself of ways to help others. Work on activities that promote feeling useful. Using breathing and relaxation. Social distraction: make plans with a neighbor to go out. Non-professional social support: daily plan, brief check-in with my son. Professional agencies, he's put all of that. Lethal means Mr. V is going to give his son the bullets from his firearms. So this is the safety plan. There are lots of examples that you can look at when you get it. Again, I highly urge you to print this, and that the good news is that for every D on this icon, there is an intervention to mitigate or prevent suicide. Absolutely means matter. That firearms kill. And in Oregon, that is the leading cause of suicidal deaths. Let me see. There are lots of evidence-based therapies for suicide prevention. We talked about safety planning as cognitive behavioral therapy, DBT. Did you know clozapine to date is the only FDA-approved indicator for reducing risk for recurrent suicidal behavior in patients with schizophrenia and schizoaffective disorder, clozapine. Do you know what the other medication is, which is often added as an adjunct for other people who may not have schizophrenia to mitigate suicide risk? Anyone wants to take a guess? Lithium. So clozapine is FDA approved. Lithium is frequently given to people who have chronic suicidal ideation. There is a special kind of CBT called CBT for suicide prevention. This is another version of safety planning which came out like before safety planning. It's called a crisis response plan, which is very similar to the safety plan. But I wanted to mention it because it's slightly different, but absolutely similar to that six-part safety plan, which we call Stanley Brown. Dialectic behavior therapy, many of you may know about that, DBT. Also very good for suicide prevention because it's heavily skill-based. In Oregon, we are also really big on this one, collaborative assessment and management of suicidality, especially among youth and younger adults, not so much in older adults. Did you know this is such a low-key intervention? It's called, caring contacts. Sending a caring text or card to say you are thinking about the person could be a life-saving intervention on its own. The use of postcards reduce suicide attempts and deaths. Telephone outreach. Did you know that sending a caring text or card as a therapist, as a ED nurse, as a case manager reduces suicide? And this is empirical. I put my citation at the bottom. And we in Oregon were actually advocating for it. Post-discharge follow-up contact with high-risk individuals may be an effective suicide prevention strategy. Caring contacts are not treatment, but can be used as adjunct to treatment, where you're sending a postcard or a caring text. We also have extreme risk protection orders, ERPO, or they're called red flags, which we are doing a lot of work on currently to actually increase awareness and education so that you can remove lethal means. I already talked about clozapine, esketamine treatment intranasal has also shown some good results, not only for depression, but for suicide too, which is ketamine. Unfortunately, the next few are really more around emergency departments. Suffices to say that people who leave the ED and or acute psychiatric hospitalizations, guess what? They are at the highest risk to complete suicide, die by suicide, after they leave the hospital or psychiatric hospital. So how much more do we need to buffer their outpatient plan? Let me see. I will let you see all this, how important it is to document, good documentation of risk, because the absence of a risk assessment is a liability to you and your organization if the person were to die. And the presence of a risk assessment in the EHR is an asset because it mitigates risk. Here are the 3 Ds of malpractice. Duty, damages, dereliction of duty, and direct causality. These are what people bring lawsuits on if their loved one died by suicide. We all know of postvention. Every person who dies by suicide leaves behind survivors who are profoundly affected by suicide. And so this whole intervention on postvention refers to programs for survivors falling dead by suicide. Again, prevention is key. And I love this. This just came out, literally. 5 actions to lower suicide wherever you are. Strengthen economic supports, create protective environments that address risk factors where people live, grow, work, and age, improve suicidal care and mental health services, promote healthy connections with opportunities for engagement, teach coping skills and problem-solving skills. Those are the interventions that we are advocating for. Are you doing any or all of these in Southern Oregon as it pertains to older adults? Take action. Sponsor workshops, teach mindfulness, teach coping skills, provide information on self-help tools and apps to promote coping. Identify common stresses targeting your population and then build their coping skills ability. Create an institutional culture that promotes and encourages qualities such as empathy, optimism, forgiveness. Implement life skills curricula wherever you are working, with clients. And provide resources and information to help people with life transitions. Here are a bunch of resources. I have 5 pages of them. You will get them all, including my email. And I thank you for being with me here today. And let's have 8 minutes for any questions or dialogue that you may have. I know I kind of hurried at the end, but those were really more broad, categories of, ED. If you worked in an ED, you will get the slide deck so you can read the specific interventions if you're an ED professional today on this training. So were there any questions, Angelas or Janine?
Yes, there is a question in chat on when you think the latest statistics will come out on suicide.
OHA has a dashboard. So please go to our dashboard. Angela, you should have access to that the link. So apps, those are the latest. Yeah. 2022 is the latest, the one I shared. So for national. But if you want our data, we have a dashboard which is absolutely wonderful because you can plug in your county, you can plug in the age group, or you can plug in means. So you can play around with the dashboard and customize the report for yourself, for your county.
And then there's another question asking, is poisoning referring to substance use ingestion?
It could, but it most often refers to medication misuse and overuse, medication overdose, but often it is mixed with alcohol. A very few, I would say, die just from alcohol poisoning as a means of suicide. Yes, there are many deaths from alcohol poisoning, but often it's a combination of alcohol and drugs which are contraindicated with alcohol. And in the United States, poisoning means medication, but in many other countries in Asia, for example, in China, the most common mode of suicide is fertilizer that they use, for crops. And in India, for many years, the most common use was rat poison to kill rats. Anything else? We are a small enough group. If you have a burning question or comment, you can even just unmute yourself.
I'm curious of the different participants of if anyone has had any training around like the QPR or the CIS training, if people want to put in the chat what suicide prevention trainings you've had.
And I was telling Angela during the break, Angela Franklin, that, I teach a 1-hour class on just writing a safety plan. And there's tons of empirical evidence that it helps people stay alive. So if any one of you are interested, let both the Angelas and Janine know. And I don't know how many of you actually do suicide risk assessments. It was part of my job for like 20 plus years, and let me tell you, as a clinician doing that, there was a great deal of moral distress, for me as a clinician, hey, am I doing the right thing? Is my assessment, accurate? And so it becomes really important to be able to have support, to have all those tools that I was talking about, those critical pathways to help support you and your decision. This is a tough job where my only job was doing suicide risk assessment. So, and it becomes painful when, all day long you're hearing stories of people in deep emotional and psychic pain. So.
Okay, well, Nirmala, I think that we are good, and we really appreciate you giving us a training. And we folks look out for the emails for your surveys, for your CEUs, and also your Portland State evaluation. Okay, is there any last comments?
So I will send you my PowerPoint, Angela Franklin, and I earlier, like this week, I sent you 2 blank templates for this. I also have a critical pathway. I'll just have to find where I've saved it, just as an example of what is what are critical pathways for suicide risk. Like it's kind of like a decision tree. So. Okay. Nice. Thank you again for inviting me. I look forward to coming back soon. Bye.
Thanks.